Good afternoon, everyone. We want to welcome you again to the August series of our IAMRAT lecture series. It promises to be a wonderful time, just like we'll be having in the time past. On behalf of the director, I want to welcome all of us to this platform. You are very welcome. We're happy to have you around. I would like to, as our tradition, I would like to brief us on the historical background of the Institute for Advanced Medical Research and Training. This institute was established in 1980 as one of the academic divisions of the College of Medicine for the coordination of multidisciplinary research in the college, and it is a response to redress the limited institutional capacity in Nigeria for strengthening training, research, and policy development in the area of health. The institute has a track record of excellent research of financial standard, channeled towards relevant local and global health problems. The institute has had a complementary trained staff with expertise in many fields of studies. I will just mention a few of them: malariology, epidemiology, statistics, cancer research, drug research, genetics, biology, entomology, neuroscience and aging medicine, with funding from many local and international agencies, which included World Health Organization, Science of Health, and so on and so forth. The institute is famous in research for infectious diseases, particularly malaria, for which it was designated a center of excellence in Africa and also in non-communicable diseases, including breast cancer, research, stroke, and dementia. The institute has numerous research and administrative units, among which the following stand out: genetics research unit, drug and cancer research unit, malaria research, molecular entomology, neuroscience and aging research unit, epidemiology and biostatistics research unit, degenerative research unit, palliative care, and the institute also hosts the UIUCH ethics unit, which is a top research ethics committee in Nigeria that was established in the year 2002. The institute is headed by the director, and the current director is Professor Ekeoluwapo O. Ajayi, and I would like to hand over to Anna for opening remarks. Thank you very much for listening.
Yeah, Director. Yes, thank you very much, Dr. Adeniji, for the information on IAMRAT. I seek this opportunity to welcome everyone to this lecture, this series, month of August. I wouldn't want to take much of our time. I can see that this is really a well-subscribed lecture. We have 108 people just in 10 minutes, and that is really a record. But I cannot but thank our lecturer of today, Professor Oladokun, who accepted to give this lecture, even at a very short notice. And I cannot but say I'm very grateful for this kind gesture. And I can assure everyone and those still joining that it's going to be a very worthwhile attendance, because the topic of today is something that is really, really mind-boggling, and there is a lot of issues around infertility and the modern technology to address it. So Professor Oladokun is here to answer our questions and to throw more light on the various modalities, their advantages and challenges. But before I go on, I noticed there is one of our big guns in O&G, one of our legends in the College of Medicine, Professor Oladipo. I noticed is with us. I can see his name. Prof, sir, we are very grateful for having you, and we are really humbled that you could join this meeting today. Others shall be recognized. I can see our legends all over here in attendance. So I welcome everyone, and before the end of the day, you shall be duly recognized. Professor Oladokun, thank you very much, and I will hand over to the person to read the citation of Professor Oladokun. Thank you all for coming.
All right. I would like to invite Dr. A.S. Bakari to read the citation of Professor Oladokun.
Thank you very much, sir. Good afternoon, everyone. We read the brief citation of Professor Adesina Oladokun before he commences his lecture. Adesina Oladokun is a professor of Obstetrics and Gynaecology, University of Ibadan, and consultant obstetrician and gynecologist to the University College Hospital, UCH Ibadan. He is a fellow of the National Postgraduate Medical College of Nigeria and West African College of Surgeons. He was a former head of Department of Obstetrics and Gynaecology, College of Medicine, University of Ibadan. He was also a former program coordinator of the reproductive health programs of the Pan-African University Life and Heart Institute of African Union Commission, University of Ibadan. He is currently the head of Infertility and Assisted Conception Unit of the department and coordinates the UCH IVF Center. Professor Oladokun is also a fellow of Nigerian Academy of Science, FNAMed. He is married with wonderful children. Please join me in welcoming Professor Oladokun as he presents the guest lecture for this month of August. Professor Oladokun, over to you, sir.
Thank you very much, Dr. Bakari, for that introduction. I want to say good afternoon to everybody, most especially what the director of IAMRAT referred to as the living legend, our teachers and grand teachers. I could see Professor Ladipo and Emeritus Professor Akande as part of the participants in this afternoon. I want to say good afternoon to my senior colleagues and colleagues both onshore and offshore, because I know that quite a number are joining us from outside the country too. And I also want to say good afternoon, most especially to the director of IAMRAT, who, like she said, she didn't even give me any option. It's like a military command for the invitation to come and give this month's lecture. And the title of the lecture, as we've been told, is Unexplained Infertility, the role of technology and application challenges. Sorry, I'm just trying to project the, I believe we can see the slide. Let me just be sure if one or two people see it, you can see it.
Yes, we can see it, Prof.
It's okay, sir.
Thank you very much.
Sir.
This is the brief outline that I will be following. Yes, of course, I know most of us on the platform this afternoon are familiar with a lot of the definitions and the points I'm going to be putting across. So, trying to introduce what infertility is all about is just part of the introduction to this lecture. And even as students, we are told that infertility is defined as failure to achieve pregnancy within 12 months of unprotected intercourse. However, some comments, some additions have been added over the years because of the availability of modern treatment methods. And so in most cases, even though you say that the couple should wait for 12 months before you can say they have challenges, however, these days, we find out that most of the time people don't wait for that before they start evaluation. In terms of epidemiology or statistics, globally, we know about 15 to 20% of couples are facing these challenges. But this percentage can be center-specific, hospital-specific, country-specific, depending on the number of factors, most especially availability of diagnostic techniques or tests and treatment modalities. It therefore means that when you look at the population affected, even though WHO stated in 2023 that it affects about 1 in every 6 people, that means about 17.5% of the adult population worldwide are affected. And this puts a figure of about 186 million people worldwide who are facing these challenges. This prevalence is probably similar across different income levels. And that was why the WHO Director General said in one of his comments that infertility does not discriminate. It affects the low income, the middle income, and the high income earner. And so when we look at the definition of health as put forward by the WHO as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, you will look at it from the emotional and psychological harms associated with infertility. Therefore, it means that it contributes a significant proportion to e-health. Infertility remains a serious medical and social problem in both advanced and developing countries, irrespective of the culture. The agony of childlessness is just as painful. But of course, as we say in the animal kingdom, we say all animals are equal, but some are more equal than the other. You find out that in African society and Nigerian community, for example, childlessness is not taken with levity. So you can imagine the agony will be more among these people. However, with the availability of assisted reproduction programs, different treatment modalities, this has really become a kind of succor to a lot of people who are affected. But however, you still have a situation where you have socio-economic and cultural other barriers or challenges facing those people who are still suffering from this condition. But the technology is available now, efficient treatment. However, this is not available to a lot of people, either because it is quite time-consuming and, more importantly, expensive. Let's just remind ourselves about how did we get to this stage. All this technology didn't just start from the celebrated birth of the baby Louis Brown in 1978. Effort at improving or providing solution to these various causes of infertility actually started decades before then. As it has been reported in the literature that the first fertilization in vitro in the animal was reported in 1969. And the first IVF pregnancy among humans actually resulted in a ectopic pregnancy in 1975. And of course, you know that between 1969 and 1975, and 1975 and 1978, a lot had gone underground in the various laboratories where these efforts were being tried before we now had the celebrated baby Louis Brown, who also has had her own baby from natural conception about 30 years after that time. In Nigeria, the first reported baby from IVF came from the pioneer work of Professor Giwa Osadia and Professor Ashiru, both at Lagos University Teaching Hospital in 1984. Now, between 1978 and present moment, we've had more than 5 million babies who have been delivered from assisted conception programs. Basically, when patients come to see us in the clinic, we go through the normal routine of reviewing their medical history, examining them, and carrying out some tests which will help us to identify what we are dealing with. And basically, these standard tests revolve around tests among the female partner and the male partner. And for the female partner, we'll start with test of ovulation function, making sure that they have challenges releasing egg. And then we look at the structural abnormalities. And these days, ultrasound assessment of the pelvic organs and hysterosalpingography of the genital tract to outline the patency of the tube are basic tests that we usually do. And this also coupled with laparoscopy in most centers now that they have that facility. Also, one test that has really become part of the routine these days is the test of ovarian reserve. And this is done either by doing the ultrasound count of the follicles in the ovary and or carrying out what we call anti-Mullerian hormone assay, serum AMH. This gives us an idea of the ovarian reserve. As we know, the woman does not produce any new eggs after birth. And so you want to know whether she still has enough eggs left in the ovary before you continue with whatever we're going to do. For the man, the basic test we do is seminal fluid analysis. This, most of the time, we can actually identify what is wrong. As we know, except in some cultural setting, they say it takes two to tango. So both men and women contribute almost equally to the causes of infertility, and the list is legendary. However, for the unexplained infertility, it is a diagnosis of exclusion for couples who fail to conceive despite regular unprotected intercourse and who do not fit the criteria for diagnosis of male factor infertility or female factor infertility, meaning that we will have carried out all the tests, if possible, or a significant number of tests in most cases, to exclude all the known causes from hormonal imbalance to structural abnormalities in the uterus or obstruction or defect. So we've had various, what I would call variants of this definition, but most importantly, most authorities have agreed that by the time we carry out these tests and we exclude all these known identifiable causes, then you can safely say you are dealing with unexplained infertility. And those things we need to exclude, those things we need to ensure will include normal ovarian function, normal genital tract, as well as normal semen analysis, and the father, the couple must be having adequate coital frequency. So apart from the International Committee for Monitoring Assisted Reproductive Technology, we also have other international bodies that have set guidelines or criteria as to how to arrive at the diagnosis of unexplained infertility. By and large, almost all of them have agreed on the guideline that you need to exclude all those identifiable or known causes of infertility before you now come up with the diagnosis of unexplained infertility. So from the International Committee for Monitoring of Assisted Reproductive Technologies, to National Institute for Health and Care Excellence and American College of Obstetrics and Gynaecology, as well as the European Society of Human Reproduction and Embryology, there is a convergence of criteria or guidelines as to how to make diagnosis of unexplained infertility. And the underlying point or the baseline or the denominator is that there should not be any identified structural, hormonal, or other factors contributing to or affecting or causing infertility. So that makes the prevalence of unexplained infertility to be highly subjective and variable. Like I said earlier on, it depends on the testing criteria available. It depends on the methodology and the technology available in different clinics, in different hospitals, and different countries. So it means that the more advanced the country is, the more advanced the laboratory is, the less will be the figure of unexplained infertility that will be detected in that environment. And so, this is just to highlight the point I've been talking about. A systematic review by a group of researchers recruited couples with suspected unexplained infertility. They use variable inclusion criteria. And then what did they find? The issue about what to do with the unexplained infertility is very germane. Since you cannot identify any particular factor, do you continue to wait, what we call expectant management? And when you want to wait, for how long? Especially when you're dealing with older couples, how long are you going to wait? You can say, well, for younger couples, maybe they still have some years by which they can actually achieve this naturally. But for older couple, it's going to be very difficult. And that is why even in some, when you check some literatures, you find the age 35 years as being used as cutoff. But that is for statistics. For the people affected, whether they are 30 years, 35 years, 40 years, they tell you that they can't wait. Doctor, let's do something. Again, the other factor about expectant management is duration of infertility. Okay, will you say, okay, for those who are just starting, maybe they are not even up to 1 year, should they wait for another 1 year? Or for those who have been in it for quite some time, do you want to start immediately in terms of investigation and treatment? Again, these are couple specific in terms of the choice, because oftentimes they will tell you they can't wait, or they've tried this, they've tried that. So the issue now is, what do you do as a first-line treatment option? Expectant management, stimulated intrauterine insemination, or go straight to in vitro fertilization. So the decision-making process between the clinicians and the patients regarding the optimal treatment plan for unexplained infertility is a complex one. And so you probably have to, what we do in most cases is to take individual couples as a case study, rather than just using what we call a general criteria or guideline in deciding what to do at that time. So, irrespective of the guidelines put forward by these various international bodies I mentioned earlier on, including ESTRI, the European Society for Human Reproduction and Embryology. How has technology helped? Technology has helped in the diagnosis, in the treatment, monitoring, and research innovations, meaning that every stage of this complex situation, modern technology has really helped. And so the main role of technology is to uncover hidden causes, optimize treatment outcomes, and personalize fertility care. And so if we are to break it down, When we talk of the role of technology in the diagnosis, we're talking of availability of high resolution ultrasound, 3D, and in a number of cases these days, even 4D, including Doppler ultrasound to outline the uterine artery velocimetry and detect some subtle uterine abnormalities or ovarian abnormalities. Also, hysteroscopy and laparoscopy these days are with enhanced imaging techniques allows for the detection of micropolyps, endometriosis, or additions that are not visible on routine scans and HSG. The same thing with magnetic resonance imaging technique, which you can use in a situation where you are suspecting some uterine anomalies, especially structural or congenital anomalies. Also, as part of the diagnostic techniques that modern technologies have really helped, we're talking of genetic testing these days, because most of the cases in the past that were classified as unexplained infertility were actually result of genetic problems in the individual, both men and women. And so studies have been carried out and shown that in the number of genetic mutation and chromosomal abnormalities that have now been identified with genome sequencing techniques contribute significantly to those cases that we either to call or refer to as unexplained infertility. In a study, systematic review carried out among some carried out in Sudan, gene expression level of leptin, mRNA, and some biomarkers have been found to be quite significantly elevated in unexplained infertility. And so, genomic sequencing and proteomics provide insight into embryo quality, implantation failure, and hidden causes of infertility. You will agree with me that though these areas of diagnostic techniques are available in a number of clinics, mostly in advanced countries, therefore, in those places where you don't have the access to these particular diagnostic techniques, of course, the incidence or the prevalence of unexplained infertility will be higher. And so these advancements allow for a more comprehensive understanding of the genetic factors influencing fertility outcomes. Apart from genetic studies and availability of other high-tech diagnostic machines and equipment, when we talk of treatment of the people with unexplained infertility, there has been a lot of contribution of the modern technology in providing support to these people, right from ovulation induction with monitoring to intrauterine insemination and in vitro fertilization itself. A lot of women have really benefited from this. And just to remind us, at the time we had the first successful birth from IVF of Lil Brown, the main reason or the main indication for the IVF at that time was tubal factor. Now, with technology, IVF is carried out for various causes, virtually all the causes of infertility, including those ones that we refer to as unexplained infertility. And even when you suspect some abnormal sperm parameters, especially if you're able to carry out some of these advanced tests, then intracytoplasmic sperm injection is readily available for those who suffer from that affliction. And so, in a number of cases, these available technologies have improved embryo selection to the extent that these days, you don't just transfer any embryo you see. You can actually grade this embryo to be able to pick the ones that you think have a better chance of implantation and continuous pregnancy growth. Also, in a number of cases, when you suspect some genetic or chromosomal abnormalities, we can actually carry out pre-implantation genetic testing to screen these embryos and pick the ones that are devoid of those mutations, so as to increase the pregnancy success rate in this individual. And so technologies have really helped us in treating these people, in even determining the number of embryos to be transferred. So much so that ASTRIN, American Society for Reproductive Medicine, European Society of Human Reproduction and Embryology, have actually included it in their guidelines that in most cases, you only have to transfer one embryo by the time you do your grading and you find the one with the best quality. And so that has really improved the pregnancy rate as well as take-home baby rate among these people. Also, technology has really helped in carrying out what we call in vitro culture of follicles. These are situations where you aspirate eggs from immature follicles, and then in the incubator, you can actually mature them first before you carry out fertilization with the available sperm. And this has also helped the people with these problems. Again, for a number of reasons, we can actually cryopreserve these eggs or sperm and even the embryo to be used at a later date for different reasons. For some people, maybe the woman or the man is about to undergo cancer treatment, and we know that these chemotherapeutic agents are actually injurious to these germ cells. So you can actually harvest these gametes, these eggs and the sperm, cryopreserve, and when the patient is done with the treatment, you can now come back with IVF, and then they still be able to have their pregnancies. Or you use a surrogate mother. I'm going to make one or two comments about that one later. The other area that is already gaining grants in a number of places, especially in the advanced countries and advanced clinics, is what we call endometrial receptivity array. Sorry, it's not analysis, whereby we determine the readiness of the endometrium for the embryo transfer and implantation. Because especially in cases of women with recurrent implantation failure, because we do know that in a number of these women, there are inherent endometrial challenges, endometrial problem, thin endometrium that doesn't have enough glandular cells to help in the implantation of the embryo. And so this has really helped them a lot. Also, what is also gaining ground these days is what we call infusion of platelet-rich plasma. And this is done by just collecting the blood sample of the patient and spinning it and collecting the plasma. One, you inject into the ovarian tissue, and this has been found to improve the ovarian reserve. Again, this is done for those particular cases that you have identified as having maybe ovarian failure, or those who we refer to as poor responder, and you are not able to harvest satisfactory eggs after repeated stimulation. And also injecting this platelet-rich plasma into the endometrial cavity to enhance the endometrial thickness, meaning you improve the glandular, hyperplasia activity of the endometrium. And this has been found to improve implantation. This is just to show us some of the studies that have been carried out on the use of platelet-rich plasma to improve the success rate among this group of patients. And it's been found to really help them. For those who had the PRP injected into the ovarian tissue, they found that the number of oocytes obtained during the oocyte pickup has increased tremendously. And this is the same improvement occur when they inject this into the endometrial cavity, of course, before the embryo transfer. And so the use of platelet-rich plasma has been found to improve not only the ovarian reserve in those that had injection into the ovarian tissue, but also those who had it injected into the endometrial cavity. It has helped in improving the thin endometrial pattern to a good thick endometrial pattern, which is receptive to implantation of the embryo that's been transferred in them. However, the limitation of these studies I quoted, they are using different treatment protocols, and this has really hampered the comparability of the results across the board. But of course, in the next few years, we'll get better results with better improvement in the methodology. Also, in the monitoring and support technologies that is available, of course, these days, you know that you can actually have some apps, fertility apps, that will advise the couple or the woman on what to do, when to do, and how to do some of these things. Even from tracking the basal body temperature that usually change, especially at the time of ovulation. So it has really helped in determining the time of ovulation in some of these women. And so they can optimize the timing of the intercourse or even the treatment at the various fertility clinics that is available in all the countries. Telemedicine, of course, has really helped the number of fertility specialists, not only in getting ideas from other people who have been doing these particular or using these methods, and also to follow up with the care and getting advice on how to do it from those who have succeeded. These days, artificial intelligence is now the rave of the moment and is being used in a number of cases to predict the success rates at different interventions based on the patient-specific data. So, what do we call the emerging and experimental technologies that is gaining grants? Nowadays, we don't just say, okay, the sperm, the seminal fluid analysis is normal because the count is normal, the motility is normal, and every other parameter is normal according to WHO criteria. But we do know that there could be some microscopic problems, DNA fragmentation. And so the use of ICSI, intracytoplasmic sperm injection, whereby we're able to select the healthiest looking sperm to inject it into the oocyte directly, helps a lot. And this is really gaining grants in most clinics nowadays where they have the facility, although the cost is one of the challenges. Stem cell-based therapies are now available. Platelet-rich plasma is a good example, whereby you can enhance or improve the ovarian reserve as well as endometrial receptivity when you use this platelet-rich plasma. Well, I came across this, what you call artificial gametes and uterine models under research for individuals with severe infertility. Of course, precision medicine is also gaining grants in a number of centers These are artificial intelligence-driven analysis of genetics, proteomics, and metabolomics problems associated or that these individuals are facing presently. A word or two about what third-party reproduction. Third-party reproduction refers to the use of someone outside the intended parents to help achieve pregnancy. And this someone outside the intended parents can be the person that will donate the eggs, or the person that will donate the sperm, or the person that will donate the embryo, or the person that will agree to carry the pregnancy herself. And that's the use of gestational carrier in surrogacy. It plays an important role in infertility care, especially when conventional treatment and assisted reproductive technologies are not successful or possible. So this third-party reproduction are not usually the first line. It's probably after you've tried the couple's gamete and it's not working that you resort to any of these third-party options. But it's not, while it plays significant role in those people with gamete dysfunction, these days is so common that you readily recourse to the use of donors, either for the eggs or for the sperm. And then surrogate mothers, especially if the intending mother, has serious structural abnormalities or problems with the uterus, even with adenomyosis, or you realize that they have some genetic risk, or they have some medical challenges, especially some of these serious mental health challenges like bipolar disorders, and they're on serious medication. And you know that some of these medications are actually teratogenic. And so for those couples, the use of surrogates might be better for them. And so this option of third-party reproduction, whether the use of donor eggs, those who donate eggs or those who donate the sperm or the surrogate mothers, they help the infertile couples a lot. And in countries where same-sex couples are allowed, yes, they are also resorting to the use of surrogate mothers to carry the babies for them. And of course, we do know that single parents are also making use of this third-party option. A good example is one of the CNN anchor person who actually posted her own experience on, I think, Instagram page or social media page. And that's, what's her name now? It's as you say, at the age of 41, she went for donor programs and she's carrying her baby right now. However, the use of third-party reproduction requires careful ethical, psychological, and legal considerations to safeguard all parties involved. What about artificial intelligence? It is revolutionizing infertility diagnosis and treatment by analyzing large data sets, identifying patterns, and providing predictive insights. So it's like doing what we call precision medicine. It enhances assisted reproductive technologies by improving embryo and sperm selection and optimizing treatment protocols. However, ethical and practical challenges such as data privacy and algorithmic-based biases must be addressed to ensure responsible integration into reproductive healthcare. This is an emerging procedure, and so nobody has all the information about how to circumvent or how to protect the individuals from all these challenges of data privacy and co. How do we measure success in this technology? Most of the time, the numerators, what people have used in the past, biochemical pregnancy, clinical pregnancy, ongoing pregnancy, live birth, and then whether they end up with multiple birth. And the denominators have been variously used, maybe the clinical pregnancy per embryo transfer, ongoing pregnancy or live birth per oocyte retrieved, or per started number of IVF cycles, or women or couple. But by and large, what is more acceptable epidemiologically nowadays is live birth as the numerator, and then you can say the number of cycle or embryo transfer, sorry. Because most of the time, clients, when they come to the clinic, the first question they ask you in a number of cases, what is your success rate? And when they say your success rate, they are not interested in maybe the number of biochemical pregnancy or the number of clinical pregnancies you get. Just quickly, why do you have this biochemical clinical ongoing? Is because of the fact that a number of them will result in positive pregnancy tests, but they fail to develop. Some developed during the first trimester, but they end up with miscarriages, just like natural pregnancies. So that's why most of the time these days we deal with live birth. How successful is some of these techniques? For intrauterine insemination, general report 10 to 20%. Even our own study in Nigeria, sometime in 2017, reported a success rate of 12%. For the IVF, mostly in most clinics across the globe, 30% is taken. But of course, some clinics will record more than that. Some have recorded up to 40. Some have even recorded up to 45. And some are still recording maybe 20, 25%. But this fertilization rate has increased tremendously with the advancement in the technology that is being used, especially with the use of intracytoplasmic sperm injection. But like I said, this pregnancy rate varies from clinics to clinics, depending on what is available there. What are the things that determine the success rate of all these procedures? The age of the woman is paramount. The older they become, the less the chances of even getting quality eggs, not to talk of fertilized, good quality embryo. Now, the duration of the pregnancy is closely related to, the duration of the infertility is closely related to the female age, because, of course, the longer the infertility, it means that that woman is going to be of advanced, what we call advanced maternal age. And the number of oocytes retrieved during pickup, which is a reflection of the ovarian reserve, one, and the quality of the oocytes, two. In some cases, studies have shown that the basal follicle stimulating hormone levels is a significant predictor of the success of the IVF treatment. And of course, the cause of infertility. A situation where you can compare the rate of the success rate among women with adenomyosis with those who just have tuber blockage. Also, the history, the previous pregnancy history, the body mass index, which is a function of the metabolism of the individual, especially the metabolism of the sex hormones, the ovarian reserve, the embryo parameters that I mentioned earlier on, the quality when you are doing the grading of the embryo, and the semen parameters, they all have been found to significantly affect the success of this IVF treatment. Now, people are worried too. Now, okay, this manipulation, this technology, how will it impact on the child outcome? So far, searching through the literature, there is no evidence so far of increased congenital malformation among the children born with the use of this technology. Now, some studies have actually emphasized that most children tend to be well catered for. Of course, that's down to reason. When you go through this effort to get that child, certainly that's not the kind of child you allow to be treated with just routinely like any other child. You pay more attention to such a child. And so they are well catered. No significant adverse effects have been found from the eggs, the sperm, and the embryo that have been cryopreserved that are now used to carry out this procedure. However, when you cryopreserve, and then when it gets to the time that you need to use this, of course, it has to go through the process of thawing, vitrification, and co. What you get might not be the exact number that you put in. Like if you cryopreserve 10 eggs, by the time you want to use it for the fertilization, the one you are going to get that will be viable might not be up to that 10 anymore. Apart from that number that is affected, what you are going to use, if you pick up a good grade egg and the embryo after thawing, you are likely to end up with a good pregnancy success rate. Now, a word or two about the consequences of the use of this technology. Of course, top on the list is what we call ovarian hyperstimulation syndrome, which result from the use of these agents that are used to stimulate the woman so as to harvest a good number of eggs. Some of them, when they end up with this ovarian hyperstimulation syndrome, they can have serious medical challenges. Basically, full retention in the third space, and they end up with hemoconcentration. They can actually have acute kidney injury from reduced blood flow to the kidney, and they end up with that. In fact, some have been have to be rescued with hemodialysis to be able to get them to their feet again. Multiple birth is one of the consequences too, and that's why S3, R-stream, and these in advanced countries, they have strict protocol or guideline as to the number of embryo you can transfer so as to minimize the incidence of multiple birth because of its effects on the mother and the egg facilities too. Preterm infants, yes, especially in mothers with medical challenges that you now have to deliver them prematurely. And of course, there is increased rate of operative deliveries among these people who have been helped with this technology. Well, there's no doubt that you can have procedural-related problems, especially when you are doing ovum pickup. Patient can actually bleed internally, although it's a rare complication, but you have to bear that in mind. People have talked about ovarian cancer, especially when you are stimulating the ovary with some of these hormone drugs. But don't forget that these drugs are actually like hormones in the body, except that they are synthetically produced. And so, again, going through the literature, there has not been any evidence of significant increase of ovarian cancer among women who have been subjected to this stimulation. Psychological and emotional effects, especially with pregnancy failure. There is no doubt that the post-treatment counseling for these individuals is not the kind of exercise a lot of us really want to witness all the time because it's not easy. It's quite emotionally challenging. There has been some cases of pelvic abscess following egg retrieval. Of course, like any other surgical procedure, you can end up with infection. Ectopic pregnancy, like I said, the first human IVF procedure recorded with pregnancy actually end up with ectopic pregnancy. So it's possible. Now, spontaneous abortion, they occur just like the rate in among those who are naturally conceived. So, technology in unexplained infertility offers tremendous hope for a lot of individuals, a lot of couples. However, it is still limited by diagnostic uncertainty because you don't have one medicine fit all test, variable treatment outcomes, which are predicted by a number of factors, like I mentioned earlier on, age of the individual, and it's a lot of financial burden for a lot of couples. How much more if you have to go through some of these in countries with strict protocols, guidelines, and even laws, they've been able to take care of that. But in a number of other countries where you don't have these guidelines widely available, then you end up, you see, oftentimes people go open the pages of newspaper and they start reading some unsatisfactory episode or comment or scenarios. So there's a lot of ethical issues involved in the management of these cases and the use of the technology. Yes, I mentioned the issue of emotional burdens, especially when you have repeated or recurrent failure, either implantation failure or failure of ovarian reserve. And in a number of cases, even the published papers are not giving enough evidence to either say this is outrightly effective or, depending on whether you are dealing with grade A, grade B, or grade C evidence. And of course, most importantly, availability of equipment and skilled providers is actually a problem of most developing countries. But of course, we have to balance the available technological innovation, evidence-based practice, and patient-centered care all together before we start advising them on what to do. What are the other challenges of management, especially in this environment? Availability of a number of this technology is a challenge. Cost is a challenge. Cultural and religious issues, economic and social consideration often influence the couple's choice. I've come across a number of couples that will say, okay, this particular method you are suggesting is against their religious belief. And so you have to take all these things into consideration. The need for infertility treatment far exceeds the availability of facilities and expertise, especially in developing countries like Nigeria. Another issue of some of these things that some patients will actually come with specific requests, especially those who are looking for a particular sex. Sorry, I just suddenly realized that I saw the Zoom scrolling on my system, meaning that I've been logged out. I think this was the last slide that I was projecting. So, availability of governing laws. In Nigeria, we don't have that, but the Association for Reproductive and Family Health actually is trying its best to lead the vanguard to provide these safety guidelines and protocols, not only to help the various fertility clinics littered all over the country, but also to protect the couples and other people that will be involved, like those who are involved with the third-party reproduction I mentioned earlier on, those who are donating eggs, donating sperm, and even the surrogate mothers. For now, we cannot curtail the proliferation of centers in Nigeria. Sorry. And then that brings us to a lot of ethical issues. At what age will you say you are not offering this service, or you are not giving them the opportunity to benefit from this technology? The problem with age limitation is, where do you draw the line? You know, the older you are, the older the women are, the more the chances of having medical challenges like hypertension, diabetes, with their complications, especially when they are poorly managed. And this can be escalated with pregnancy. And in fact, even some of these people can have some problems with giving them some of these hormonal treatments at old age. What about single parenthood? Here you are talking about the care of the child. But again, even in countries where they have the protocols in place, the laws in place, single parents with strict criteria can still access this technology. The one that is more or less like the wave of the moment nowadays is what you do with the cryopreserved gametes and embryo, especially when the couples are separated or divorced, and or when one or both couples are deceased. These are serious ethical issues that we have to contend with. Again, in countries where sexual orientation is gaining ground, some of them where they have strict laws or guidelines concerning sexual orientation, they move to another country that is liberal, get what they want, and get back to their native country with their babies. So how do you curtail that? Transborder transaction. Selective embryo reduction, again, in countries where they have laws that stipulate you cannot transfer more than one, they've been able to have this particular selective embryo reduction curtailed, so they don't end up with multiple pregnancy. But of course, in Nigeria and other developing countries where we place so much premium, in fact, some people walk to the fertility clinic and request that you transfer as many embryos as possible so as to increase the chances of having more babies at a go, something I usually call or refer to as buy one, get one free, bulk of. Surrogacy is another major area for these people with unexplained infertility. Surrogacy is available to them, but we have to protect the rights of the surrogate mother as we are protecting the rights and the demands of the intending couple. This also poses some ethical challenges. Gene therapy is an area that is evolving. Some people are against it. They say you are carrying your manipulation to a level that may not be controlled. So controlling this is another issue that is posing some ethical challenges. Anything in the future? Yes, I mentioned earlier on, artificial intelligence is gaining grounds. And of course, these days, you keep on seeing some postings in the social media about some laboratories in some Chinese provinces where they are now growing artificial wombs and growing babies in the artificial womb. Again, it might appear like Star Wars, but don't forget that some of these things, maybe they're already practicing or trying it out, but with some ethical issues. So in the near future, maybe it's not even future, maybe it's even with us already, not just for the purpose of Star Wars. Thank you for your attention. I hope I've been able to keep the number. These are some of the references. Wow, 198 people. Thank you. Thank you, thank you. Over to you, Professor Ikejayi, Dr. Deniji, and Dr. Bakri. Hello, I hope people are hearing me. Hello.
Yes, sir, you are loud and clear.
Thank you very much. I'm just trying to check the chat box. But don't forget that there was a time I was off the line, so I may not be able to have all the questions there. But maybe Dr. Adeniji, Dr. Bakari, or Professor Ikejayi can help me with that. Yes, I can see my teachers and grand teachers. Thank you, sir, Professor Ladipo. Thank you, Emeritus Professor Oluwole Akande, and all my teachers who have listened to this presentation. Over to you, coordinator. Hello? Oh. Dr. Bakari. Dr. Adeniji. Uh-oh. The host has muted everyone. No wonder. Now, I don't know whether the host is hearing me now, so that they can unmute people, those who want to ask questions.
Hello.
We can hear you now.
Yes.
We can hear you now, sir. We can talk now.
Good afternoon. My name is Professor Mwasimbelu. I'm standing in to handle the question and answer session. And I want to especially thank some of our legends that are here. I can see Professor Ladipo, Professor Toluri, Professor Migbodun, Professor Gedegbe, all over the country. There are many of them. Professor Oladokun has treated us to a very fantastic lecture this afternoon. And the reaction and applause that has been coming in testify to that. I would also like to recognize the presence of former director of IAMRAT. I can see Professor Falade and Professor Falusi at a point joining the meeting. I think without wasting time, I will ask our guest lecturer to please look through if there are some of the questions, and if you can attend to them. But I can copy the ones that I have seen here. But I would like to start with Professor Ajayi's specific question to you, sir. He said, Professor, please, what is your advice for patients on the number of ova to transfer to achieve multiple pregnancy?
Okay,
and
thank
you. How do you also clarify this with respect to the risk of miscarriage and the risk of maternal morbidity?
Actually, he has answered the question partly. It is because of those challenges that is generally advised not to transfer more than 2. And like I said earlier on, even ESTRI, the European Society for Human Reproduction and Embryology, and American Society for Reproductive Medicine, in their guidelines, actually put it that you should transfer 1, so as to mitigate the problems of multiple pregnancy and its complication, as well as increased risk of spontaneous miscarriage. However, I know that is on paper, but do people practice it in various clinics? That is a challenge. While it is advised not to transfer more than 1, at most 2, some people still end up transferring 3 or 4. The problems with that is it has also affect the implantation. So you end up with implantation failure. And where you are able to achieve pregnancy, you end up with multiple pregnancy of higher order with its attendant complications, increased spontaneous miscarriages, increased risk of preterm labor, preterm delivery, with its attendant prematurity of those babies. So because of all this, it is advisable not to transfer more than two.
So thank you so much, sir, for that question. I think there is another question that thought-provoking is asking. Hello, I think we should
Hello.
other people that are not speaking. That
there's one question about why don't we have
yes, that's what I want to ask you. Why don't we have regulations on ART in Nigeria?
Okay.
Okay, please go ahead.
Like I said earlier on, presently we do not have what we call laws on IVF or assisted reproduction in the country. But, there's somebody said that Lagos State has something. What Lagos State has was actually pioneered or championed by the Association for Reproductive and Family Health, Association for Fertility and Reproductive Health, which almost all the practitioners of this art belong to in the country. And so it is hoped that this will spread to other states of the country so as to have firm control about the practice in a way that will protect not only the parent or the intending parent, the patient, not only the clinics offering these services, but even the pregnancy and the children that result from these treatment modalities. That is one of the activities of the ARFH. So hopefully we will get to the stage where we have what we call the laws or regulations that is binding on everybody in the country. But right now, I know Lagos State has those things, which, like I said, were pioneered or championed by the Association for Fertility and Reproductive Health.
Okay, thank you so much, Prof. Just to add, sir, that the Medical and Dental Council of Nigeria actually set up, I think, about a 10-man committee during Dr. Sanusi's period as the registrar of a Medical and Dental Council of Nigeria to streamline things based on petition that has been submitted for disciplinary action.
Yes.
And a draft of a regulation for the country was proposed. Dr. Wada was the chair. So, but I don't know at what level is that draft. I think it's something that association should be able to.
Yes, the draft that you mentioned before the Medical and Dental Council is still there. And activities of Medical and Dental Council have been hampered by the fact that there is no council right now. So I guess that's partly why nothing much has been done about that, because they need to move from just draft level to getting it as the guideline or criteria or the laws for the entire country. It hasn't moved forward since there has been a change of guard in that council.
Okay, I think there's another question here by Shaibu Joseph. Does cryopreservation affect the quality of embryo when is being transferred at a later date? does it affect the offsprings in terms of intelligence?
I said earlier on that when you cryopreserve 10, by the time you are going through the process of thawing and vitrification, you may not get that entire 10 of the same quality again. But by the time you do your grading, you'll still be able to pick the one you refer to as the good quality embryo. Whether the DNA, the chromosomal properties inside that particular embryo is going to be affected by the process of thawing. There is no evidence to point to that presently. And that's why people are still using cryopreserved either eggs or embryos so far.
Yeah, thank you. Professor Ademowo is asking, what is your take on the use of cloning as an alternative to IVF? What are the moral and legal implications?
Cloning. Hello?
Yes, cloning. Cloning, use
Very
of
good
cloning
question.
as an alternative to IVF. What are the
Very
moral and legal?
Yes, very good question. Let me refer to that ship called Dolly that resulted from cloning procedure maybe some 40 years ago. The global outcry against it, which bordered on ethical issues, that means the scientists have now gone beyond reasonable level in manipulating things, actually made people to just, well, I would say suspended that thing at that time, because they succeeded in cloning the dolly ship that died later, not necessarily because of any genetic manipulation, but the fear that if they extend it to human beings, then some people will just sit down in one lab and start producing giant or some specific individuals targeted for specific purposes. These are some of the things that made it not to be popular. But you see, right now we are talking of stem cell therapy. By the time people widely accept that stem cell therapy as in taking care of people with infertility and unexplained infertility, you will see what I foresee is a gradual acceptance. And then people will draw up some ethical guidelines and say, okay, well, we don't want you to go beyond this level. As scientists, I'm not too sure you can stop it altogether. What we can do is to see how we can safeguard the product of such procedure ethically. Because we know that even something that is so simple, people can misuse it. And that is the fear out there.
Okay, another one, what is the role of sacrilege to forestall abortion?
Standard practice, you put cervical sacrilege in patients that is indicated. What do I mean? The patient has been having recurrent mid-trimestral miscarriage that you alluded to or you think is caused by cervical incompetence. However, I've seen a number of patients going for IVF treatment, successful pregnancy test, and thereafter, in quote, they were given what is called prophylactic sacrilege. Scientifically, medically, clinically, that is not indicated. It's an overkill. But you see, a lot of these procedures are carried out in private clinics, and private establishment is for profit organization, not non-profit organization. So offering this particular procedure to me is like trying to make extra coins from something that is not indicated at all. Hello?
Yes, we can hear you. I'm just trying to look at the next one.
Yes, I'm looking.
We need to be cognizant of immunological hazard that prevents implantation of the embryo. Well, this is just a comment. Is there a maximum number of embryo transfer that can be attempted before resorting to surrogacy? That is number of IVF.
Number of IVF cycle.
Yes, in an individual group, you advise the person to go for surrogacy.
Yes. Well, again, you know, one of the slides, I said the decision to treat between the clinician and the client or the patient is an individual thing. Some people have seen a patient undergoing 8 treatment cycles before eventually getting a successful pregnancy. So if you had asked that one to stop after 6 attempts or 7th attempt, she won't have a baby today. So it has to be individualized. Because to start with, it's not a free service anyway. It's a lot of money. So it's an individual thing. If you fail once, you want to try again, it depends on your carrying capacity. And that is why some people, they would, after discussing with their provider, their specialists, their doctors, they would decide that, okay, I'm not trying again. I'm not trying as an individual again. Let's go for surrogacy.
So, Professor, one of our fathers that attended your talk, Professor Ladipo, asked, what is the role of micro and nanoplastics in infertility?
Thank you very much, sir. I can only answer a guess now. Especially at whether it will affect what we call the ovarian reserve, it's a possibility. Whether it will affect the endometrial receptivity, it's a possibility. Because all these changes happen at the micro level. So when you are exposed to these nano agents, whether it will affect the functionality of the ovarian tissue and or the endometrial tissue, they are possible. That's my take. And of course, they will contribute to the increasing number of the unexplained infertility. Because again, identifying this is not something that is readily available in most of our laboratories. So I agree with Prof that it's possible that this could actually play a significant role in the cases of infertility that we have to deal with. Why are there such few studies on IUI in the country? To start with, even when you are discussing with the client, with the patient, you know that the success rate following IUI is much lower than the success rate following IVF. So a number of people just go straight for the IVF that has a better chance. And so that also will affect when people do some of these procedures. Update on local experience and usage. Yes, in the last 5 years that we've started functional activities at the UCH IVF Center. And don't forget that the building itself had been in existence for upward of, is it 12 or 14 years now? We've had our own teaching challenges, but we've been improving on that. Even though we don't have all these arrays of technologies that I mentioned, but we have a good number of these technologies to carry on, and then we've been perfecting our activities to the extent that at least we are recording reasonable successes among our clients up to date. And apart from the challenges of electricity and coal, we are doing the procedures on a fairly regular basis now. Are there facilities for indigent patients in Nigeria to help them afford fertility services? Are there organizations that can provide financial aid? There are two questions in one here. Are there organizations that provide financial aid? I'm aware that some banks actually do that. They have some programs. And even in our center in UCH, Access Bank tried to run a program. They call it Mother something. They have a name for it, whereby they will advance the money for those who access that facilities. Now, whether there is maybe a reduced cost or charges for patients in Nigeria, don't forget that most of these services are carried out in private establishments, and these private establishments are not Red Cross Society or Red Crescent Society. They are for-profit organizations. Very few public institutions or public teaching hospitals actually run this program. And that is where you can have reduced cost compared to the private clinics. Very few public teaching hospitals run this. Ibadan, Lagos, Jos, National Hospital in Abuja. I'm not too sure of UPTH in Port Harcourt now. These are the ones I'm aware of, because we do communicate. We have a meeting ground. For those who want CME from this, I think Professor Ikajaya has posted the link that they can access. Any role for endocrine disruptors in unexplained infertility? Yes. Yes. These are some of the predictors of the success of the treatment procedures in unexplained infertility, because they affect this ovarian function especially, and then how the endometrium is stimulated significantly. Yes. Reproductive cloning of humans is banned all over the years. It has never happened, and I pray that it won't happen. Dr. Bola Ndeola from UK said reproductive cloning is a good comment of human is banned all over the world. It has never happened. And as far as we know, it won't. However, therapeutic cloning for stem cells is allowed legally in some countries. Yes, I mentioned the use of stem cell during the lecture to grow stem cell harvesting for treatment. Yes. Okay, I think we've gone through all the questions that are posted. Over to you, Professor Moasimbelo. Professor Moasimbelo. Am I to
Hello,
unmute
sir.
everybody?
So, Hello. Yes, because we are taking the question, that's why I decided to leave it for you so that
Yes, and I was saying that. What?
Yeah. So what is left is to appreciate you, sir, for accepting to give this talk. At the height of, at the peak hour of your presentation, I think we had 240 people that attended.
Okay.
240. I think the director is back.
Yes.
I will hand over to her to do the closing remarks and to let everyone know that another interesting topic will be delivered next month. Over to you, ma'am.
Okay, thank you very much, Professor Masimbelo. I think I'll still hand over to you to round up, but just to thank Professor Oladokun and all our legendaries, yes, our senseless and our international collaborators and others. So Professor Masimbelo, please continue and please recognize all that we are to recognize. Everyone is important. We appreciate your coming. Thank you very much. So over to you, Professor Masimbelo. Thank you.
So on behalf of the director, the management and all the senior member of academic staff of IAMRAT, I want to especially thank Professor Adesina Oladokun for agreeing to give this important lecture. Infertility is an emotional, highly sensitive topic, and more sensitive is the role of technology in its care. Both the clinician and the clients are usually very apprehensive of the whole process and its outcome. And I believe all of us has learned well from it, from the clinical perspective. And it has also highlighted potential area of research, including basic and clinical science research potential that we need to do. And I think this was also highlighted by a few people challenging that why are there relatively low local evidence? And this further underscored the importance of multi-center collaboration to generate data that will be very impactful and influence policy in Nigeria. So I want to thank Professor Ladipo, Professor Tolurin, Professor Falade, Professor Migbodun, and a host of other senior people all over Africa, including UK, Professor Mr. Bolariwa Ola, who had joined from UK, and our immediate past head of department, Professor Odukogbe, in Obs and Gynae, who also joined, and our colleagues all over the country who are joined to learn one or two things. So it's been a wonderful evening, and I thank every one of you, and I wish everyone a nice evening. Bye. See you next month.
Bye-bye.
Bye.
Thank you very much, Prof.
Thank you, ma.
Thank you, sir.
Thank you so much, oh. So I can sleep now.
Bye-bye, Professor Oladokun. Thank you.
Thank you so much, Prof. Thank you.
Thank you, Prof.
Good job,
Don't go and sleep, oh. Don't go and sleep, oh, Prof.
Yeah.
Don't go and sleep yet, oh. Go and take Amala.